It's a great pleasure and an honour to be here as the spokesperson, really, on behalf of the NPDA. I'm also a stakeholder. I run a clinic in Cardiff, and I've been involved in this audit as the clinical lead for the last 6 years, which is why I've lost most of my hair. But this is a celebration event because there's a lot been happening over that 6 years. And I'm going to show you some of the 15-16 data today. And as Fiona says, that is unpublished at the moment. We have got permission from our funders, HQIP, some of them are in the audience today, to show you that data. But you can't take that further than this room today. So the audit has actually been running for 13 years. It was originally run by the NHS Information Centre, and then the HSCIC, and then the Royal College took it over in 2011, which is when I became more heavily involved. And to the bottom here is the 6 years of the audit report, and here is the one that you're going to see on the 21st of February. I've already seen it, so I know what's in it. But every year we've produced this report, and it's been a labour of love, and a lot of people have been working hard at it. But it's your data. You're the people who've worked hard to produce it and submit it to us. So 6 years ago, when I put my hand up and applied for this post, I rather wondered what I'd let myself in for. I was told it was 4 meetings a year and a couple of emails. And of course it was a lot more than that and still remains that. But I can remember in the early days, and that's only 2011, when the first report came out and people said to me, well, that's fine, but the data's wrong. We don't believe anything you're putting out. You're taking our data, you're changing it, you're manipulating, and that's not what I gave you. I said, well, that's what you submitted to us, and that's what we analysed. And as we moved on, then people started to say, yeah, okay, the data's correct, but there isn't really a problem. We're getting on with it. We're seeing the children they're going through, and we're getting rid of them into adult services eventually. And then people go and say, okay, the data's right, perhaps it is a problem, we're not doing particularly well, but it's not my problem, it's your problem. And then so when we were able to start demonstrating through benchmarking that perhaps you did have a problem with the service you were providing. And I think now we've moved to a stage where people really are starting to accept the data and say, yes, it is my responsibility to do something with it and to improve my service if I'm not doing as well as my neighbour up the road. So I think we are moving into these realms of quality improvement. So just to remind you, there are now 173 centres in England and Wales that participate in this audit. There were 178 when I started, so we've lost 5 somewhere along the line. They've actually merged is what's happened. The audit criteria is to collect data on coverage and participation, on demographics, care process and treatment outcomes, including targets, hospital admissions and patient experience. And I'm not going to talk about hospital admissions today. Deborah will talk about patient experience. And we're now, when I started 6 years ago, we were around about 50% of units were submitting data to the audit. And we've now, over the last 6 years, been at 100%. And we remain at 100% over the last 6 years. So what are the numbers? This is the latest report here. We're up to about 28,500 children in England and Wales who've been submitted to the audit. About 95% of those will have type 1 diabetes. The other 5% are a mixture of type 2, CF-related diabetes and other forms of diabetes. And you'll see in this year's report, we've actually highlighted the type 2 and put some data in about them separately. You all know that diabetes is a growing problem, and we rank about 4th in Europe in terms of the incidence of diabetes, and we'll hear from Ragnar shortly where they have a higher incidence than we do in the UK. But as we all know, it is steadily increasing, and I'll show you some incidence data shortly. So I'm going to take you back a little bit to 2007, 2008, and this is where we were. We were static. We had a pretty poor HbA1c, and if we compared ourselves to European counterparts, we were not doing very well. And if I took this graph back, even back to 2003, it pretty much showed exactly the same HbA1c. And I apologise, I will flip sometimes between percentages and millimoles per mole. So in that report in 2007, 2008, Dr. Sheila Shribnam, who many of you will remember was the National Clinical Director for Children and Young People and Maternity Services at that time, she was asked to write the foreword for that report. And she wrote, "This disappointing situation cannot be allowed to continue. Action to prevent and manage acute and long-term complications of diabetes must start on day one of diagnosis and continue lifelong. NICE produced clear guidance 5 years ago and more recently. Why has so little progress been made in implementing it?" It was quite a powerful statement which made many of us quiver a little bit. And she went on to say, "Act now. The progression of diabetes is relentless. We have the knowledge. We need to use it and take responsibility and benchmark our efforts against others in order to improve further. Children and young people deserve nothing less." And that was quite an inspiration to many of us to think about how we can improve things. Many of you will have seen this flower before. I've been accused of calling it Fiona's flower, but it is a flower that belongs to Fiona. And it stood the strength of time, because I think you made this about 6 or 7 years ago, and it was really to think about how you can think about quality improvement and improving outcomes. And so this flower is about developing networks which are the driver for service improvement, and these networks need to be embedded in this sort of safe, effective, efficient, sustainable managerial jargon type speak. But all these little petals around here are all about quality improvement, and they're all about areas that you can think about in trying to drive improvements in your service. But I think the three tripod areas, if you like, which I feel have led to massive improvements are these. The best practice tariff in England has given you money to do things, and this is now, we don't have best practice tariff in Wales, but we are beginning to get some investment through health boards now. The peer review programme, the quality assurance, has led to massive improvements. And I like to think my little bit over here, which is producing these reports, is also driving outcomes. And I'm going to talk about the audit. I'm not going to talk about peer review. So this is Lord Deming. He was the founder of the modern day audit. He wasn't a medic. Really, audit didn't come into the health service until the early 90s, probably, when people started to think about doing audit. But he described this quality service improvement tool. He was an industrialist. He made cars. And what he described was this PDSA cycle of improvement. So you plan something, you have a standard that you want to aspire to, and we have that in terms of NICE, ISPAD, and other guidelines. And then you go out and you collect data against that standard, which is what we do in the audit. You then study it and produce some recommendations, which then hopefully you act upon and complete that audit cycle. And you go round and round that cycle as many times as you like per year or every other year, driving up the service. And what we've not been very good at, I think, going back to 2007, was this bit. We never completed the cycle. So we were pretty good at doing the first 3 quarters of this, but not acting upon it. And that is happening now, and change is beginning to show. So what do we do from the audit in trying to report your data so it has maximum impact when it hits the floor? Well, we're guided a little bit by our funders, the Healthcare Quality Improvement Partnership, and this is their reporting guidance. So in the centre here, you have the commissioners of the audit, and then people who receive the care, people who deliver it, such as yourself, the people who regulate it, such as CQC, and the people who commission care. So we produce a national high-level audit report at national and regional level. We will be producing them at CCG level, as from this year as well. For our patients, and Kate's led a lot of this work, we produce a parent and carers report, though I understand that's actually the one that most doctors and nurses read as well. We produce the individual unit level reports to help you understand where your unit sits. We've done 3 PREM, patient experience measures, which Deborah will talk about later. And we're beginning to do some work now with the CQC, which is going to come your way, and many of you may have read this CCG outcomes indicator set, and HbA1c has managed to get in there as a CCG outcome indicator set for children. And we're also doing some work with HQIP on clinical service quality measures, and I'll mention these briefly later on. So this is where we are, 2015-16 data. This is the incidence broken down by age, and I said at the beginning we all know that diabetes incidence is increasing, but no more so than this group here. And this is what everyone tells you, it's the younger children we're seeing more and more of. And there's been pretty much a doubling over the 6 years that I've been involved with this audit in terms of the incidence of under 4s. The other age groups up and down a little bit, but no clear pattern of increase. And of course these are the children who will be with us longer and are more at risk of complications because they will have diabetes for longer. So let me start with the care processes, and NICE currently recommends 7 care processes. When I started this, these were the care processes: HbA1c, body mass index, blood pressure, retinopathy screening, foot care, microalbuminuria, and cholesterol levels. And there's always been this big debate about whether cholesterol should be in there, and sadly for me, NICE removed it in their 2015 report, and we've now replaced that 7th care process with thyroid function, which is in there. So there's always a little bit of difficulty comparing this year's 7 care processes with last year's, because one of them has changed. But this is the completion rate, and this is a good news story, really. Each of the individual care processes is represented by the bars, and you can see year on year, including the 2015-16 data, there's been a gradual improvement. All of these now are over 50% completed in each individual patient, and some of them approaching 100%. If you look at completion of all 7, so you only have to miss 1 and then you don't get any brownie points at all. When I started back here, this was 1 in 20 children was completing all 7. That is now 1 in 3, and I think that is a tremendous statistic, a tremendous change. You will never ever get 100%. We never will do, because we know people don't turn up for appointments and things, so you'll never get that. So I think 1 in 3 is pretty good. I'd like to see it better, but it is a dramatic improvement. And if you look at this at regional network level, so you'll see each of your networks here along the bottom. This is the 14-15 completion rate, and this is the 15-16 completion rate. Who's here from the northeast? What did you do? Dramatic improvement from just over 10% to 40%. So you've done something different. I think maybe your register is what's made the difference, but you've been the top award improver over the last year. But every network has improved, as you can see. Everyone has incremented over the last year. But of course there is still variability, so now we come down to the unit level. So this is a funnel plot. Don't get too worried about the statistics. So each of these squares represents one of you, a diabetes unit. This is the number of patients within your unit above 12, because the guidance is only above 12 for certain of the care processes, and this is your completion rate. So the big line down here is the average, 35%, and all the units are spread around that, and the funnels are created to show you the confidence limits. So when I put the colour codes on here, these are units up here who are performing exceedingly well compared to the average. I'm not saying it's brilliant, but it's well above the average. And these are units who are performing poorly. And you can see there are still quite a few units who either are not doing these care processes, which I don't like to believe, or they don't have the IT systems in order to submit them to the National Paediatric Diabetes Audit. And I would urge you to try and work with your IT so you can submit, because CQC are hot on our tails and they will take 0 as 0. You haven't done it, and they'll be after you for it. You can of course look at your individual level reports. This is actually last year's, so you can get a funnel plot like this where the red shows your own unit, the big blues are other units within your region, and the little tiny dots are the other units in England and Wales. So you can get a position of where you sit. So let me turn to HbA1c. This is what everyone always likes to see. So I showed you this before, this lack of change up till about 2009, 2010. And then this is what's happened over the last 6 years. A gradual and steady improvement in HbA1c. And I know you're all waiting for me to reveal the question mark, which I am able to reveal to you. And it's a really good news story because this is where we are in 2015, 2016. So this is an 8 millimole reduction over 6 years on average, which is a fantastic improvement. Why has it happened? Well, it's happened because you're out there working hard with the children to improve their diabetes care. But the things that have allowed you to do that are the development of the regional networks. In England initially, this was followed by best practice tariff, followed by peer review quality assurance programs in England. There was a delivery plan in England, which was followed by one in Wales. Quality assurance came into Wales. Regional networks started to develop in Wales in 2015, and we're now into this sort of QI, quality assurance, consolidation phase, which is what we're talking about today. So what does this mean? What does that mean, an 8 millimole reduction in HbA1c? We haven't done any proper health economics on that. We tend to move into that into the next realm of the audit. But you'll all have seen this graph before about risk of microvascular complications associated with glucose control. And there's no such thing as no risk in diabetes, even when you're down here to very good HbA1cs down to 6.5%, 48 millimoles per mole. There's still not no risk. There is some risk, but it's considerably better than up here. And it's reckoned that a 1% or an 11 millimole reduction in HbA1c will reduce your risk by about 37%. What does that mean in real terms? So I've done a bit of calculations on the back of a fag packet, and I'm sure you could argue with me that these are incorrect, but 8 millimoles, 0.07% improvement in H1C. This is a potential reduction in microvascular complication of about 25%, which would be equivalent to about 7,000 children less in England and Wales suffering a microvascular complication. And when you think of the cost of that to the health service, and this is financial cost, this doesn't include the burden of cost to that family or to that patient. Dialysis will cost you about £30,000 a year. A kidney transplant is 17. A leg amputation is about 32,000. The cost of blindness, which is all causes of blindness, which diabetes represents a big portion of that, is 4.9 billion is the cost of blindness. So the 75 million which is spent on best practice every year is probably saving money in the long run. We are moving at quite a speed with the improvements. I know Fiona would say, we're not going fast enough, Can we go faster and faster? She drives the whip. So I've just showed you a couple of experiences from other European countries. So this is Germany, this is the German-Austrian DPV register, and this was their improvement over 15 years, and they were improving at a rate of 0.038% per year, 0.04, which is about half a millimole per year. So we're improving almost double that rate at the moment. And this is the Swedish data from Ragnar, and he'll probably allude to this later on. But if you look at theirs over 15 years, they went from an HbA1c on 3 different cohorts, but they went from HbA1c about 66 down to about 58 over 14 years. And again, we're improving at a much faster rate. We've got work to do to get to where they are, but we're improving at a tremendous rate. Every network has improved. So this is similar to what I showed you before. Here's your network along the bottom here, the 14-15 result and the 15-16 result. And every network has improved. We win the game here in Wales. So I'm from Wales. I'm not Welsh, but I'm from Wales. So we've won the award this year for the biggest improver in HbA1c. There are, of course, a lot of cofactors when influence HbA1c. When I first started this, people say, well, I'm doing badly because I have a lot of adolescents in my clinic, I live in a very deprived area or an ethnic minority area. So we do now try to take that all into account in terms of adjusting the data, and you can see how each of these cofactors does influence HbA1c. So this is duration, this is gender, this is deprivation, and this is ethnicity. So they all do affect it. So we build this into a model. So when we provide you with this funnel plot and your data back, it might be slightly different to what you sent us because it's been adjusted for your case mix. So it allows you to compare yourself directly against an opposing unit. And you can see there's still a huge amount of variability across all the units in HbA1c across England and Wales. So up the top here, these are the less well-performing units, and down the bottom there are the slightly better performing units. And again, you can go and get your unit level report here, which shows you your own individual, those within your region, and the other units up and down the country. So you might be able to take yourself a pat on the back at this stage and say, we've done the job done, we'll just carry on and let it carry on as it is. But of course, everything you see is not always what it seems to be, and there is still more work to come. And we've been doing quite a bit of work with your data in terms of international collaborations now, and looking at, we've started looking at HbA1c, which is the obvious point to start. So these are 8 countries that we've been collaborating with, and this was work that's been led by Demetrius, and I can't pronounce his surname, Charlamopoulos, from the Child Policy Research Unit, who went out to Germany where they collected all the data from these different registries and analysed this. And you can see, if you line these countries up in terms of average HbA1c, which is the red line, and this is the spread, you can see we still rank fairly poorly down the end there. This is 2014 data against Sweden, which we'll hear about at the moment, who is the top ranking unit. But what is interesting about this data is when you start to look at the spread of individual units, it's very different across different countries. So if you look at Sweden, for instance, so this is the Swedish, this is taking an individual unit and looking at the spread of the average HbA1c, and you can see Sweden, very good average, almost in line with ISPAD guidance, with a low centre of spread. So there's very little spread across their units, units performing fairly equally across the country. Whereas if you look at Germany, who have a very good outcome as well, their spread is much, much wider. So a good average, but a large spread. So they clearly have centres achieving as badly, for want of a better word, as we have in our country, but they also have centres performing extremely well up here. And then you look at, this is England, with a relatively poor average, but a moderate spread. And so in terms of quality improvement, what we need to do is march this graph from this in this direction and squeeze the limits a little bit, so we pull in those that are not doing quite so well. This is the UK data, so this is Demetrius's data. This is just UK. So what he's done here is to adjust your mean HbA1c for your case mix, as I talked about before. And then he's lined your unit up against the mean. So this is the mean, this red line, for the country. And then each of these lines represents a unit, and they're lined up in order. So these that are up here have a residual above the average, and these ones have a residual below the average. So these are well-performing units, poorly performing units. And what is interesting here is that you can see there are a series of units here. There's about 20 of them who are doing significantly better than any other unit in the country, and there are about a similar number of units here who are doing significantly poorer than the rest of the country. And if you put this into a statistical model, he's been able to demonstrate that nearly 5% of the variation in your HbA1c is located at clinic level. So just by moving clinic, you could perhaps change your HbA1c by 5% of its value, not 5% in terms of millimoles. And the network, which I think is really exciting, accounts for 11%. So networks are really powerful, and they are working, and I think that's good evidence for that. So we're moving into, I haven't had the 5-minute buzzer yet, no. We're moving into an area. Have you? Oh, I'll ignore you. So we're moving into, I thought this is rather clever, this slide. I think it is anyway, I made it. So this is the gold medal league table from 1996. It was the Atlanta Olympics. It was a real depth of misery for GB, who were 36th in the league table here. They had 1 gold medal. That was Stephen Redgrave and Matthew Pinsent who won the gold medal in the rowing. And even Sweden here had 2 gold medals. We were above us in the league tables. People looked at this and thought, what on earth are we doing in this country? And what happens over the next 20 odd years was a tremendous change in the thinking about how we manage and performance manage sport. And so last year at Rio, GB was second in the table, 27 gold medals, and we were above China. I mean, that was an amazing change. China up here somewhere or other back in 1996. So how did they get there? How do you get from there to there? It doesn't just happen overnight. You need quite a number of things to do that. You need resource, you need a structure, you need some sort of quality improvement and continuing improvement cycle, and you need to manage performance. And so we have that in diabetes. This is the analogy. You've been given money, you've been given best practice tariff, and we're getting money in Wales. And there is a structure now around regional networks and peer review and a measuring structure and the audit. There's lots and lots of quality improvement going on, and we'll hear about some local quality improvement later on today, but 2 big national societies as well who are trying to drive through guidelines. And then we come to the performance management bit, and we haven't really done this as yet, but it's coming your way. We're doing work with CQC and HbAlc to produce this clinical service quality measure, and CCGs are getting interested in paediatric diabetes as well. So this is the sort of thing we're doing with CQC. This is a dashboard we'll see, and they came to see us and said, we don't understand your report. We don't know how we can go into a centre and know whether they're performing well or not. So they basically wanted 2 headline results to say, is this unit an outlier or not? So we've gone for completion of care processes and your adjusted mean HbA1c, and it'll produce a little dashboard like this for them, so they'll know where you sit. So if you're in the green zone, they'll come in, they won't want to see you in paediatric diabetes because you're doing okay. If you're in the red zone, they will come and ask you some questions. They won't say you're doing badly, they'll come and ask you questions about why you're in the red zone. So that's coming your way. The CCG outcome indicator set, it will be coming your way, and that's going to include HbA1c. I think originally it didn't include any paediatric diabetes at all, but it managed to get it. And this is the guidance that they are producing to help you with your quality improvement work. And then this is the work we've been doing with HbAlc about a clinical service quality measure. So this is where you take aspects of what you've done, such as your completion of care processes, your HbA1c, and you amalgamate them into a composite score, which then say you are a green performing unit, or you're an orange performing unit, or you're a red performing unit. And we've still to work through the statistics of that, but that is going to come your way, I'm sure, sometime in the next year. So how do we, last couple of slides now, Kate, I'm nearly there. So in order to move us forward, we need innovators up this end of this graph, and there are a number of innovators in this room. We've got some speaking today. We'd like that Ragnar's come across from Sweden to talk about the Swedish experience. Deborah's going to talk about patient experience. Lots of innovators in the room. So innovators here, and there are a few of us, probably I sit here, thinking, well, yeah, okay, I'll listen to these innovators and I might do a few things. Well, the majority of us sit here, really, and we sit waiting for somebody to tell us what to do. And we need to get off our bums a little bit and say, actually, let's move into these early adopters and let's drive this whole thing forward. And I chuckled the other day when Fiona came to Wales to present to our Welsh network, because she put up this slide, because she said she's fed up with the academics saying, where's the evidence, Fiona? You know, you haven't got any evidence, but we have got evidence that the things are happening. And she described this as Professor Gregory, who some of you might know. He's not in the audience, so I can talk about him. He's the academic up here and say, well, it's all very well, Fiona, but well, you haven't got the evidence. And then she said, down here are these elephants who say, well, sod the evidence. I've got a good idea, and I'm going to go on and see whether it works. And she described it as me. She said, I was the chap who says, I want to know what those elephants over there are doing because I want to improve things. So it's amusing, but actually it tells a story. So I've come to the end, you'll be pleased to hear. So my final conclusions are that the outcomes are improving, and that's a fantastic news story. We still have to work with the variability. We need to improve that. The policy guidelines, which showed you driving that H1C down, and the funding appears to be working. The quality improvement tools need embedding, I think, within network structures and management, and we need to think about how we're going to manage performance probably at a network level. I don't do any of this on my own, and these are the people who do a lot of the hard work, the team in the RCPCH who do all the really hard work, and the people who give up their time to advise the project and lead its working. So I'm going to finish at that point. Thank you.